Hi there. Welcome to MedHustle's Hematology high-yield Harrison-based videos. Today, let's learn about DIC, that is, disseminated intravascular coagulation. As the name suggests, DIC, that is disseminated, that is all over the body, intravascular, that means inside the vessels, that is coagulation. To learn about DIC, first let's get a hang of the coagulation cascade. So, as you can see, there are two pathways of the coagulation cascade, the intrinsic pathway and the extrinsic pathway. Marker for factor deficiencies of the intrinsic pathway is the activated partial thromboplastin time, that is APTT, whereas marker for deficiencies of the extrinsic pathway is the prothrombin time. Both the pathways terminate into a common pathway. This in turn generates thrombin, which is needed for conversion of fibrinogen to fibrin. Let's know the triggers for DIC. The most common trigger is sepsis. Other important triggers include obstetric complications like abruptio placenta and amniotic fluid embolism, trauma in cases of extensive burns, fat embolism, and rhabdomyolysis. Cancers, particularly important and high yield to remember, is the acute promyelocytic leukemia, snakebite, and acute pancreatitis. Causes for chronic compensated DIC include giant hemangioma, dead fetus syndrome, and metastatic carcinoma. Learning the pathophysiology of DIC now. Basic thing which occurs due to the various causes is tissue factor activation. Now recall from our understanding of the coagulation cascade, once the tissue factor is activated, it causes increased activation of the coagulation cascade, leading to increased consumption of all the clotting factors. Remember that there is increased fibrinogen because of this activation. This fibrinogen is a nidus which causes increased platelet aggregation. Hence DIC is a consumptive coagulopathy. It causes increased consumption of both clotting factors along with platelets. Further, due to increased thrombin, there is increased fibrin in the circulation. This fibrin is degraded by increased levels of plasmin. Hence, there is increased fibrinolysis, that is hyperfibrinolysis. Hence, the reason for raised fibrin degradation products. The symptoms of DIC. Due to the consumptive coagulopathy, symptoms range from bleeding from venipuncture sites, petechiae, ecchymosis, to severe bleeding from GIT, lungs, or intracerebral bleeds. Coming to the diagnosis, as we can see, more platelets are consumed in DIC. Hence, the platelet count is low. Now, recall again about the coagulation cascade. As both factors of the intrinsic and extrinsic pathways are consumed, there is prolongation of both the activated partial thromboplastin time and the prothrombin time. But the most sensitive test is increase in the fibrin degradation products, marker of which is the D-dimer. Hence, D-dimer levels are elevated in DIC. Coming to the treatment of DIC. Mainstay of treatment is to treat the underlying cause. For management of the hemorrhagic symptoms, either FFP or cryoprecipitate is used. 1 unit of FFP replenishes most of the clotting factors by around 30%. Prothrombin time, more than 1.5 times the normal, is a sensitive indicator for consumption of the coagulation factors. Low fibrinogen levels usually requires cryoprecipitate transfusion. Role of heparin is limited. Low-grade DIC associated with solid tumors or acute promyelocytic leukemia or giant hemangiomas can benefit with heparin infusion. Do like this video and subscribe to the channel for more such videos.